Assalamu alaikum wa rahmatullahi wa barakatuh. I'm Dr. Ahmed Elhalwagy, Assistant Professor of Obstetrics and Gynecology. Our topic of discussion today will be diabetes mellitus with pregnancy. Of course, as we know that diabetes is a metabolic disorder which is characterized by either deficient insulin production or insulin insensitivity in the target organs due to deficient receptors. So there is a problem in the insulin function. This problem is called diabetes mellitus, either due to deficiency or insulin resistance due to deficient insulin receptors in the target organs. Subsequently, the body will have high blood sugar level, increased blood glucose level, diminished glycogenesis, and the use of oxidation to produce energy, which is called gluconeogenesis. Best and Panting, the scientists who introduced bovine insulin in the 20th century, in 1921, they introduced insulin for management of diabetes mellitus. Before the era of insulin as a drug, diabetes was responsible for many human deaths, very high percentage of human deaths, especially during pregnancy. Pregnant women who had diabetes have a risk of 25% mortality. That's to say that one female of 4 diabetic females, when get pregnant, she will die. This was a very high maternal mortality. And the perinatal mortality of the fetus or the newborn, perinatal mortality means death during the peripartum period, just before delivery or during delivery or after delivery. So the fetal or neonatal perinatal mortality, it was high up to 50%, which it's a very high mortality. This mortality, maternal and fetal, dropped after the use of insulin as a medication for diabetes. The maternal mortality dropped to 0 in most of the countries, and the perinatal mortality dropped to 9%, from 50% to 9%. Although it's still high when compared to the non-diabetic, the infant or the newborn of non-diabetic mother, which have a perinatal mortality of up to 3%. That's to say that there is a triple fold in diabetic women, but of course it decreased markedly from 50% before insulin introduction. Of course, we know that insulin is produced in the beta cells of islets of Langerhans in the pancreas. The function of insulin, as we said, it's mainly on the carbohydrate metabolism. It had a direct effect on the cell membrane, facilitating glucose entrance inside the cells. It helps glycogenesis or formation of glycogen in the liver and muscles, retard glycogenolysis, prevent glycogen degradation for production of energy. It helps glycolysis by oxidation of glucose in the muscles, and prevent gluconeogenesis or the formation of glucose during catabolism of proteins. The effect of insulin on lipid metabolism mainly is lipogenesis, or formation and deposition of fat cells in the adipose tissue. Now we will talk about the classifications of diabetes mellitus. There is many classifications. We will discuss the most commonly used classification. The first one is the American National Diabetes Data Group classification, which classifies diabetes or diabetic population into 4 types. Type 1, which is the insulin dependent, or what's called juvenile onset diabetes mellitus. In this type or this category, the patient who must be treated with insulin due to marked deficiency of insulin production, and usually the onset of this disease is early during childhood or early adulthood. Type 2, non-insulin dependent diabetes mellitus, in which there is enough insulin production, but there is a resistance, mainly resistance. The pathology is resistance in the target organs of using insulin due to deficient insulin receptors. So treatment, it can be without using insulin by giving insulin sensitizers, which is the oral hypoglycemic drugs used to increase the sensitivity of the target organs to insulin to manage diabetes. This is type 2. Type 3, the gestational diabetes, or the woman who discovered diabetes during pregnancy. And type 4, which is a secondary diabetes due to external factor which affect the insulin production and affects the beta cells of islets of Langerhans, like patients receiving drugs like chemotherapy, exposed to radiation, hormonal factor, pancreatic lesions like tumors, and so on. Any factor which affects the pancreas and prevent insulin production leads to type 4 or secondary diabetes. There is another classification, which is a Priscilla-White classification. Priscilla-White is a scientist who introduced this classification in 1974, which classifies, it's a very, very practical classification, although it seems difficult, but it's actually practical and helpful classification. It classifies diabetes according to the stage of the disease and the complication, symptoms and complication. In class A, the patient have no symptoms, no complaint, but diagnosed by abnormal glucose tolerance test. So we can conclude that diabetes is diagnosed by abnormal glucose tolerance test, which we will discuss later. The glucose tolerance test is the only diagnostic tool for diabetes mellitus. So class A, the patients having no symptoms, no complaint, but accidentally discovered to have diabetes. Class B, the patient having diabetes after 20 years, being 20 years old. The duration of the disease is less than 10 years, and no vascular lesions and no complications. So class B, the onset is after 20 years old, the duration is less than 10 years, and there is no complication. Class C, relatively younger onset, under the age of 20, and relatively long duration of the disease from 10 to 19 years old. 10 to 19 years duration. But also there is no complication. So class C patients having the disease before being 20, and the duration of the disease is between 10 and 19 years. Class D, still non-complicated cases, but very young onset, having the disease before being 10 years old, and very long duration, more than 20 years. So class A is non-symptomatic, B and C and D non-complicated cases, but we differentiate between them according to the age of onset and the duration of the disease. The classes coming after that is the complication, according to complication. For example, class F diabetes, the patient who having nephropathy, vascular nephropathy. Class R having retinopathy, proliferative retinopathy. RF if they have retinopathy and nephropathy. Class G, patients having diabetes complicating gestation or pregnancy capability or reproduction. So if the patient having repeated abortion, repeated preterm labor, repeated stillbirth, intrauterine fetal death, and so on, complication of diabetes which prevent reproduction and leads to bad obstetric history, they are classified as class G according to Priscilla-White. Class H, the patient having coronary heart disease. Class T, the patient having pregnancy after having renal transplantation due to renal failure. So, Priscilla-White classification is an easy one. Let us remind you with it. Class A, patient having no symptoms and accidentally discovered. B, C, and D are patients having no complications, but we differentiate between them according to the age of onset and the duration of the disease. And the classes from F, R, R, F, G, H, and T are according to the type of complication. Why I said it's easy and practical? For example, when I'm telling you that this patient is class R, Priscilla-White for diabetes, from one word you can conclude that this patient having a complication of diabetes, of having retinopathy. When I'm telling you that this patient is class D according to Priscilla-White classification, you can conclude that this patient is non-complicated, having no complication of diabetes, but this patient have a very young onset, less than 10 years, and very long duration, more than 20 years, so that you can, your mind will conclude that this patient is risky to have a complication of diabetes. There is many WHO categories. It's not a classification, it's categories for diabetes. Clinical diabetes, the patients with symptoms or complication of diabetes and diabetic response to glucose tolerance test. Chemical diabetes, it resembles the class A in Priscilla-White classification. The patient who having have no symptoms, no clinical symptoms or complications, but have abnormal glucose tolerance test. Latent diabetes, there is normal glucose tolerance test, but there is a history of diabetic glucose tolerance test during pregnancy, infection, or other stressful conditions. So when you hear the term latent diabetes, the patient is not diabetic now, but it has a history. The patient has a history of having diabetic glucose tolerance test during a stressful condition, for example, pregnancy, or during accidents and blood loss, and during severe infection, pneumonia, for example, and hospitalization, the patient have diabetes. So the patient is risky for having diabetes, of course, in the future. Potential diabetics, the patients with normal glucose tolerance test is considered having potential risk of developing if they, for example, one or both parents are diabetic, so they have strong family history. Patient having her identical twin is diabetic. This is a potential diabetic patient. She has a borne a macrosomic baby. One of her parents is diabetic and the other has a family history of diabetes. All these risk factors make you think that this patient is potential diabetic. Prediabetes describes a period of life before having diabetes to be diagnosed. So it's a retrospective diagnosis, and it used to describe the period of life before diagnosing diabetes. Gestational diabetes, which is the diabetes defined as carbohydrate intolerance, to firstly recognized during pregnancy or during labor or after labor, during the period. We will skip. No, we don't have to skip. We are going to talk about carbohydrate and lipid metabolism in pregnancy. Normally in normal pregnancy there is a resistance to insulin because rise of hormones which is produced from the placenta, like human placenta lactation, insulin, estrogen, progesterone, steroids, cortisol. All these hormones increased during insulin production during pregnancy. So it works as an anti-insulin hormones. So pregnancy is a diabetogenic condition. Also, the production of insulinase enzyme from the placenta, which is the insulin, leads to degradation of insulin, leads to high demands of insulin during pregnancy. So, as we said, it's a diabetogenic condition. On the other side, pregnancy increases the peripheral utilization of glucose, leads to around 10% reduction in the maternal glucose level. So to less extent, pregnancy helps the utilization of glucose and decrease the blood glucose level, but mainly due to the production of anti-insulin hormones from the placenta, pregnancy is considered a diabetogenic condition. Ketosis is associated with low blood sugar. It's common in the first 2 trimesters due to early morning vomiting, or what's called emesis gravidarum. Also due to lowering of the renal threshold that occurs about the 4th month and depletion of glycogen stores. In late pregnancy, ketosis is common due to increased insulin requirements. Diagnosis of diabetes. When to do screening for diabetes? We have to do screening at 2 occasions, at booking or at the very first antenatal visit. We should do screening for diabetes, and again between 24 and 28 weeks of gestation we have to do another screening wave for diabetes. Screening means sample test. Screening test is a simple test who is applicable for large number of population to separate a group. This group is risky to have the disease. Then to do the diagnostic test for this group only. We don't have to do diagnostic test. For example, in diabetes, the glucose tolerance test, we don't have to do it for all the pregnant females. But we start with screening, which is a simple test to separate a group who are risky for having diabetes and to do the glucose tolerance test. But in high-risk patients to have diabetes, like patients having positive family history, as you said, obese patients with body mass index more than 30 kilograms per square meter, patients with truncal obesity, aged gravida, multigravida, or old primary gravida, the patient having history of having macrosomic baby, unexplained stillbirth, having a history of unexplained stillbirth, or congenital malformations, or glucosuria. These group are the high risk group. We don't do screening test. We go directly to the diagnostic test. The screening test is a 50-gram random bolus, and after 1 hour we do glucose tolerance test. We give the patient 50 gram, whatever. If she is, we don't mind about if she is fasting, she is not fasting, she is whatever. We give her 50 gram glucose tolerance test, 50 gram glucose, and we do a blood glucose test after 1 hour. Or more simply, we can do random blood glucose. We don't giving the patient glucose. We're asking the patient to random blood glucose at the time of the visit and see the result. If the blood glucose is higher than 140 milligram per deciliter, the patient is suspicious to having diabetes, and we shift her to do glucose tolerance test, 1 hour, 100 gram glucose tolerance test. The diagnostic test, which is 100 gram 3-hour glucose tolerance test, the patient is coming to the laboratory fasting, from 8 to 10 hours fasting, and we take the first reading, blood sample to measure the fasting blood sugar. Then we give her 100 gram of oral glucose and test for blood sugar after 1 hour, after 2 hours, and after 3 hours. According to the cut values described on the screen, fasting should be less than 95, 1 hour should be less than 165 milligram per deciliter, 2 hours less than 145, and 3 hours less than 125 milligram per deciliter, 125. If we have two of these four values elevated than the cut-off value, the patient is considered to have diabetes. There is another laboratory test which is very helpful in management of diabetes, like glycosylated hemoglobin, hemoglobin A1C. Of course, you know that there is a part of hemoglobin which is attached to glucose. The level of hemoglobin A1C in the first trimester are higher than the non-diabetic. It's used, the glucose hemoglobin A1C or glycosylated hemoglobin, it's used for evaluation of the control of the blood glucose in the last 3 to 4 months, which is the lifespan of the RBCs. The lifespan of the RBCs is from 90 to 120 days or 3 to 4 months. So when we measure the glycosylated hemoglobin, we can take an idea about the control in the last 3 to 4 months. The level of hemoglobin A1C, the normal level, is between 4 and 7. This means a good control of diabetes. The best control that hemoglobin A1C is less than 5.8%. This is the best control, but it's accepted to have it up to 7, from 4 to 7%. From 7 to 10% hemoglobin A1C means bad control of diabetes. If it is higher than 10%, this means no control or very bad control for diabetes. What's the effect of diabetes on pregnancy? Effect on pregnancy means effect on the mother and the fetus. The maternal effect of diabetes: increased incidence of abortion and preterm labor, increased incidence of polyhydramnios, increased incidence of preeclampsia, increased incidence of infections, especially valvitis, increased incidence of infections, particularly puerperal sepsis and renal infection, pyelitis, and so on. Why the mother having polyhydramnios during pregnancy if she is diabetic? Because of the polyuria of the fetus. Of course, we know that 90% of the amniotic fluid formation, it comes from fetal urine. So as the mother having hyperglycemia, the baby also will have hyperglycemia and polyuria. So production of fetal urine will be increased, leading to polyhydramnios. The fetal complications of diabetes include increased incidence of congenital anomalies. It's about 6.3% in diabetic, or in the infant of diabetic mother, which is triple-fold the normal incidence of congenital malformation, which is about from 2 to 3%. Also fetal macrosomia, especially muscle mass and adipose tissue and organomegaly. And macrosomia, of course, leads to increased risk of traumatic delivery, shoulder dystocia, and increased cesarean section rate. The macrosomia is due to hyperglycemia and fetal hyperinsulinemia. The mother is diabetic, but the baby or the fetus is not diabetic. So when he exposed to hyperglycemia coming from the mother, he produces insulin, and insulin have a growth hormone like action. With the availability of the energy due to hyperglycemia, the insulin will increase the mass of the muscles and adipose tissue and also organomegaly, leading to fetal macrosomia. Also, the fetus of the diabetic mother is exposed to intrauterine fetal death. Why? Many factors may cause intrauterine fetal death in the infant of diabetic mother, or in the fetus of the diabetic mother. The first is the congenital malformation. Those babies is exposed, as we said, to higher level of higher instance of congenital malformation. So this intrauterine fetal death may be due to congenital malformation. Also, due to variation of the blood glucose level in the maternal serum may affect the fetus, especially hypoglycemia. If the mother having hypoglycemia, especially in the last trimester, this exposes the fetus to severe hypoglycemia because he is used to produce large amount of insulin in response to the maternal hypoglycemia. So when he is exposed to maternal hypoglycemia, with his insulin production is increased, this will lead to severe hypoglycemia in the fetus, which may cause death. Also, severe hyperglycemia and ketoacidosis may lead to intrauterine fetal death. Also, those fetuses are exposed to high neonatal death or death after delivery. Why the IDM or the infant of diabetic mother is exposed to high rate of neonatal death? Due to malformation, due to hypoglycemia after delivery, because of the sudden deprivation of the glucose coming from maternal circulation, with the hyperinsulinemia leads to severe fetal hypoglycemia, which lead to neonatal death, and infant of diabetic mother may be having respiratory distress syndrome due to deficient surfactant production in the lung and lung immaturity. So after birth, they have a hairline membrane disease and respiratory distress syndrome, and this may be the cause of this. Those infants have a risk of having diabetes later on in their life. The anomalies in the IDM may be neural anomalies like anencephaly, microcephaly, encephalocele, cardiac anomalies like transposition or septal defects, either atrial or ventricular septal defects, or transposition of great vessels, phallotetralogy, and so on. And the cardiac anomalies is the most common anomalies seen in the infant of diabetic mother. But the most specific anomalies is what's called sacral agenesis or caudal regression syndrome. Sacral agenesis, there is no formation of the sacrum. Although this complication is rare, but it is very specific for the infant of diabetic mother. And also thumb deformities, renal deformities like renal agenesis or double ureter or malformed renal pelvis or whatever. These are the anomalies expected to be seen in the infant of diabetic mother. This picture showing anencephaly, fetus with anencephaly, no vault of the skull. This fetus having microcephaly or craniostenosis or early fusion of the cranial bones. This MRI picture showing a fetus having no sacrum or what's called sacral agenesis. This is a picture of showing skin maceration due to intrauterine fetal death. When the baby have intrauterine fetal death and still in utero for more than 48 hours, his skin starts to macerate like this. So we can conclude that this fetus is died more than 48 hours. the management of diabetes will be discussed in another lecture, inshallah. Thank you very much. Hopefully that you get benefit from this lecture till we start another lecture of management.